Good morning, everyone, or afternoon, wherever you might be. We're here with the representing the supply chain management subgroup of the Community Case Management Task Force. We're a small group of people who are interested in the supply chain components who meet regularly to sort of make resources available related to supply chain and community case management. My name is Alexis Heaton, and I am a country technical manager on the Supply Chains for Community Case Management project with JSI. And I will be co-presenting with my colleague Jane Briggs, who will introduce herself. Jane, are you able?
Hello, can you hear me?
Yes.
Okay, good. Sorry, I was having problems with the mute function there. Good morning, everybody. My name is Jane. As Alexis mentioned, we'll be co-presenting this. I work with the CHWs program. CHWs stands for Systems for Improving Access to Pharmaceuticals and Service. It's a program of the MSH, Management Sciences for Health. So as Alexis said, this is a webinar that has been prepared by the Supply Chain Management subgroup of the CCM Task Force. It's actually our third webinar in a series of webinars on supply chain management issues that are relevant to CCM. So let me go ahead and start giving you an overview of what the objective of the webinar is. We hope to provide an overview of quantification, focusing on some of the unique considerations of quantification for CCM and potential options to address the common challenges that we often encounter. Now, it needs to be clear from this stage that we're not going to provide a detailed how-to session on quantification. It's a very complex area. There are a lot of technical resources that already exist for quantification. And what we want to do with this webinar is to focus on what is specific to CCM and the considerations that need to be taken into account when you're going through a quantification exercise for CCM. For the target audience, well, it's for all of you that are on the line now, and for anybody else that can access the presentation online afterwards. We want to target staff that are involved in NGOs, engaged in providing technical assistance to Ministry of Health programs in quantification for CCM, or those that are conducting quantification for their own programs. So either those supporting the Ministry of Health programs or working on their own parallel programs. So let's put quantification into context. What is it that we need? We need to get products to the community. So CCM brings treatment closer to the community, but frequently relies on the same source and flow of products that are used by health facilities. And as we know, community health workers are right at the end of that supply chain. And so unless medicines are fully funded and in full supply throughout the system, community health workers are the most vulnerable to shortages and the most likely to face stockouts if there is not a deliberate effort to ensure that products reach them. So for example, if you take a case where a health center has got a supply of medicines and they're running out of a certain product, rather than distribute it to the community health workers, they're going to keep it for use at their own level. And especially this is going to be a problem if there are performance-based financing indicators related to availability and stockout periods in the health facility. So this means that if we haven't got careful planning, and careful planning means that there has to be quantification and an enabling funding and policy environment, among other things, but community health workers could run into a problem of having enough medicines to treat all of the sick children who come to see them. And so it's very important that we need to ensure that there are enough medicines for both the health center use, which is also in many cases a referral point, as well as the community health workers themselves. And so quantification is the first step in ensuring that there are enough products in the system so that community health workers have the supplies that they need to treat the sick children they're supposed to treat. So what is quantification? Quantification answers the question, how much will be procured and when will it be delivered? It consists of two stages. The first stage is forecasting. Forecasting is the estimation of the quantities as well as the costs of products that are required for a specific health program over a specific period of time. So that's the first stage. The second stage in quantification is supply planning, and this is a process of determining when the products should be delivered to prevent interruptions in the supply. So these are the two major components of a quantification exercise, but it's very important that many consider quantification to be an art and not a science. And this is something that we have to keep in the back of our mind all the way through this presentation and through the exercises of quantification that you're involved in. There is no right or wrong answer. The idea is to find the best fit based on the best information that we have, so that you've got the best likely output, and then that needs to be continually revised. So there is no right and wrong answer. It's an art, not a science. So this slide shows the process of quantification. We had a definition that was fairly clear. Quantification is made up of two components, forecasting and supply planning. But this slide actually shows us very nicely that the process is quite complex. And this diagram actually comes from Quantification of Health Commodities, a guide to forecasting and supply planning for procurement, which is a document produced by the Deliver project of USAID. And this diagram nicely shows that there's a lot of extra stages involved, and that the process is not just as simple as those two main steps that we presented earlier. And I'm not going to dwell on each of the steps in this process, but the idea is really to show that there is more involved. And the preparation at the very top of the slide there is crucial. And really, there shouldn't be any shortcuts in that preparation phase. You need to make sure that you've got data compiled, and that data needs to be as good a quality as possibly can be. And sometimes that's a real challenge to obtain both the data itself and data of good quality. And so the process goes through the slide from preparation into the forecasting stage, and we'll go into more details on that in a minute, into supply planning, and we'll explain a little bit more about what the supply planning is. And then there's a kind of iterative process where you look at what the output of the forecasting is and the supply plan that you get, and whether the funds that you have in existence are sufficient, whether you need to adjust because of the funding problems and make different adjustments to the assumptions, and that process goes on until eventually you get to the procurement stage of this cycle. Now, it's very important to bear in mind that this complex process is not a one-person task. This isn't one person sitting in an office with a load of data, plugging all the data into an Excel spreadsheet, and then coming out with an answer. For quantification to be done efficiently, to be done effectively, it really needs to involve a multidisciplinary team that have different backgrounds so that you can assure the best output. And that way that we can be more sure that the forecast that we produce and the supply plans that are produced as a result of the exercise are as accurate as possible. So what kind of data is needed for quantification? And here in this slide, we're mentioning three different types of data. The first one is historical logistics or consumption data, which is basically the quantities of products that are dispensed or used over a specified period of time. And here we've said ideally a year or more. I think it's fairly obviously ideally a year, because then it rules out issues of seasonality. So if you're covering a year period or more, the fluctuations in a disease over a period of time is ruled out. And so this kind of data can only be used where consumption data exists. And so that means that the program has to have been operating for a period of time. The other type of data we can consider is service data. And so here we're looking at number of services provided. For example, the number of children treated or referred over a specific period of time. And this can either be historical or projected in the case of expansion. The third type of data that we're looking at is demographic or morbidity data, which is population-based data. And here we're talking about numbers and characteristics of the population that is targeted for the services that we're considering, and data on prevalence or incidence of a disease or health condition in a specific population. And so it's important to assess the quality of data, to look at what's going on with the data, what's missing, what's the context, what are the gaps, and to find out more about it, ask questions. What's missing? What is misleading? To determine which kind of data should be used for your exercise. For example, if you use consumption data, that should be adjusted for stockouts or other limitations within the data. And if there's data that is missing, in that case, we have to make assumptions. And we'll talk a little bit more about assumptions in a moment. And I just want to draw on some experience that we had in one country where we were going through this exercise of using the demographic morbidity data. And in actual fact, looking at the population data, we had three different options of population data that could be used. There was data that was used for planning the vaccination program. There was data that the health centers and the districts used for their own estimates. And then there was also census data of the population, which dated back to 1996. And each of those sets of data was different. And so the team in country, and again, I emphasize the word team, had to look at that data and see which was the one that should be used because there were differences between them. And so that's the importance of having this team involved to go through that analysis process and look at which of the data was more appropriate. And so in the end, they decided to take the census population, even though it was dated, but adding a percentage increase for each year to cover the increase in the population. And also they had problems because they didn't have country-specific incidence data on the diseases that they were wanting to include in their package. And so they used regional data, again, estimates from the literature. And then obviously that shows why it's important to sort of revise this as we go through, and we'll mention that over and over again, that the revision process in this exercise is very important as you get more and more experience in the implementation of the program. So a forecast should ideally use multiple types of data. And here we have an example of 3 different sets of data looking at ORS sachets. And I just want to show you that it isn't straightforward, and this can sometimes be quite confusing. The red line, which is a flat line at the 180,000 line, is showing a monthly consumption, a projected monthly consumption of ORS over a period of a year, which is based on incidence data. So this is morbidity data. So many children should be getting, in the population, should be getting diarrhea, and so this should be the theoretical consumption of ORS. The blue line is showing a calculated consumption of ORS based on service data, so the cases of diarrhea reported in the HMIS system. And you can see that there's a difference. And the purple line is another different line again, is showing us the data that comes from the LMIS, the Logistics Management Information System, on actual reported consumption of ORS over that period of time, so for the last 9 months of this year under study. And so you can see here that there are huge differences between these different types of projected consumption. And what do? Do you take an average? Do you plump for something in the middle? Well, remember we said that quantification is an art and not a science. And so what has to happen here is that we need to explore what's going on with this different type of data so that we can make the best guess at the end. So with the red line, the morbidity consumption, is that really realistic? Here we're suggesting that there's a coverage of 100%, that every single child that gets diarrhea will receive ORS. Is that realistic? Aren't there seasonality patterns? How realistic is that morbidity consumption? And then taking a look at the purple line, have there been stockouts? Because if there have been stockouts, that doesn't actually represent the real demand or what the actual consumption would have been. Is all the data complete? Have there been facilities that didn't send in the data? And then the blue line, similar types of questions. Is this the actual coverage for the projected period of time? Will there be more community health workers trained? And are the reports complete? And so we have this big gap between the red line, the blue line, and the purple line. And this big gap here can be confusing to people when they're going through a quantification exercise. And so which one do you use? If you use the red line, the danger is that you're going to have an overestimate of your forecasting because coverage isn't at 100%. If you use the purple line, you may be overlooking the fact that over the last 3 months of the year there'd been a huge out of stock, and so again it would be an underestimate of your actual consumption. So your forecasting would be an underestimate. If you look at the blue line, you're forgetting that there's going to be another 500 community health workers trained in the next few months, and so the demand is going to increase, and so you're going to need more. And so again, that would lead you to an underestimate if you use that data. And so here we can't say, okay, so the actual figure that you should use is a monthly consumption of 60,000 or 70,000. But what is important is that the team sits down and goes through the data to make their best informed estimates. And so for new programs, what are the alternatives to consumption data? Consumption data is obviously ideal, but in new programs where CCM is being set up, consumption data and service data may not be available. And so here, morbidity-based estimates may be necessary for CCM if programs are still new or are in an early phase. And so what you would want is that the program should ideally transition to consumption-based forecasts once that data, the consumption data, is routinely captured and if reporting is regular. And this is showing us that there is a real reason to, a need to establish a logistic management information system that tracks that community level consumption data from early on. And another example from our experience providing assistance to a country is that this tracking system was set up in a country where there was a new CCM program put in place. And so the community level health workers were tracking their consumption data, but unfortunately there was weak supervision of that system, and the information was not consolidated at each level. And so at the health center level, the district level, we didn't have that consumption data available, and the only level that data was available was at the actual community health worker level, which is not useful for carrying out a forecasting exercise. And so whatever method of forecasting is used, it's very important to document all the assumptions so that you can go back and review them, revise them as you go along, as data becomes more available, as you get more experience with implementation. And all exercises of forecasting include at least one assumption. Even if it's only the planned expansion or the scale up of the program, there's at least one assumption that is made in an exercise of forecasting. And these assumptions are made by multidisciplinary teams, and as time goes by and there's more experience in implementation, the assumption needs to be refined, and this turns it into a cyclical process of forecasting and revision and forecasting and revision. And so here, just to give us a bit of a reality check on forecasting. Even if we have data that's high quality, we still need to, in some cases, make certain assumptions, and those certain assumptions could be on issues related to the expected uptake of services, the impact of changing program policies or products that may be happening along the way, service capacity. What about client access to services? Seasonality of service demand or disease burden. All of these are assumptions that may still need to be made even though you have good quality data. Geographic variation between one district and another, and any other factor that might impact on demand, such as, for example, if community health workers are close to health centers, do they see less patients? So all of these things have to be taken into consideration, and certain assumptions need to be made. And so here we need to document those assumptions. And so you have to carefully document when the assumption was made, what the assumption actually is, and what data it is based on, so that when you want to come back and revise and revisit, you have that documented and it's easier to make the changes. And now the reality check. Let's be realistic about our scale-up rates and the patterns of use. If you assume immediate service availability, that every community health worker is immediately going to be treating all of the sick children in their area, and service use at scale, you're going to end up with an overestimate of your need. You'll have too much product in the system. You're going to risk misuse of the product, diversion of the products, and even expiry. So we really have to be realistic. Are we really going to train 500 community health workers every month for the next year? Are we going to have sufficient supplies for them to be operational as soon as they're supplied? Do you have the medicine boxes and all the other types of supplies, not just the medicines themselves? And also to check that your outputs are reasonable. Do a ballpark check of the answers that you're getting in your forecast. If you have a population of 2 million children under 5 and your forecast gives you an answer of 20 million ORS sachets, is that really realistic? Let's do a quick ballpark reality check on that. And so we said that the second part of quantification exercise was the supply chain, the supply plan rather, sorry. The supply plan indicates when products are required in country to fill the pipeline and meet the forecasted need. And so this plans out the delivery of stock and when those procurements or orders should be placed. The supply plan has to use the forecast. So the data that you produce in your forecasting exercise has to be used in the supply plan, but it takes into consideration other types of data as well. So you have to consider the timing and the availability of funding, because only once you've got the funding can you do the procurement. So that has to be part of that supply plan. The stock on hand in the system, the kinds of products that you've got, the amounts of products at every stage in the system, and any orders that are already in place that are still waiting to be received, so they're in process. Take into account the estimated supplier lead time for your products. If a certain product has a supplier lead time of 6 months because it's an international procurement and it takes a long time for that to actually arrive, you have to take that into account in the plan, and the considerations will be different from something that's more locally produced and can be obtained within a month, for example. So take that supplier lead time into consideration. And also your desired stock levels, your maximum and your minimums that have been established related to storage capacity of the system. So the supply plan should guide coordination and procurement. but not the forecast. The forecast is produced first, and that's then what's feeding into the supply plan, and the supply plan then goes on to guide coordination and procurement. So I'm going to hand over to Alexis now, who will continue the presentation, and she's going to start off by showing us what a supply plan will look like and how it can be used.
Thank you, Jane. Yes, so what's in front of you is the supply plan, and this is just an example of what it might look like, just to sort of take any of the mystery away. I think a lot of people know that you can use software to develop a supply plan, but it also can be done with a simple Excel spreadsheet, and the concepts are basic. So you add in the forecast consumption from your forecast that you've done. So it's as your input, as your starting point, and then looking at what you currently have in stock for that product, then estimate how you'll draw down on that stock over time and when you would need additional quantities of products to come in. So as you can see from this example here, in August, maybe you know that a donor has planned a shipment to arrive of 400,000 then. So that helps you then estimate, assuming you're at the central level, determining when after that you would need another shipment to arrive. And that last column there on months of stock tells you then when it's getting low. And from the top you can see many systems have a minimum stock level that's set, so take into account, as Jane had mentioned, what the procurement lead time would be, and the amount of buffer stock in your system, and how long your pipeline is, and how much you need to ensure a continuous supply and availability of products. And so the supply plan really is a monitoring tool that allows you to see how to monitor your stock levels. And what you would do with this is use it on a monthly basis as you start to see actual consumption, and compare that to what you forecast and update and revise accordingly. So if for some reason in August you started to see that your consumption was going up, you would then be running out of products sooner and need to plan additional shipments accordingly. So I think as Jane had mentioned earlier, quantification is cyclical. It's not a one-time activity, and that's a really critical message to it's something that needs to be revisited quite frequently, especially when you have a new program or a program where your forecast is based on a lot of assumptions. It's important to look at it regularly, adjust your supply plan, and then go back to your forecast, make those adjustments to your assumptions, or maybe you have better information on your consumption. Only this constant monitoring that will allow you to make sure that you avoid stockouts and overstocks. I think a lot of people have a tendency to think, well, quantification is something we do once a year, we write the report, we share it, and then it's done. But really it's something that requires continuous monitoring and review. And so there are some common challenges for doing quantification for CCM, and I think, many of us that having worked in this area are probably familiar with these, but just to sort of restate them. A lot of CCM programs don't yet have strong reporting systems, so getting the data that you might ideally have to do a quantification, they may be unavailable or incomplete. What we've seen in a number of countries is the way that the reporting system has been set up is that the data from the CHWs, as far as consumption and logistics data, has been aggregated with health center level before it reaches the central level. So it's not possible to break out what percentage of that consumption you're seeing is from the amounts actually used or required by the. Another big challenge that Jane also mentioned earlier is that these programs are often, a lot of them are new or still, and so even if you have good data, it's hard to be confident in the trends that you're seeing and the variations that you're seeing. There may be ongoing scale-up efforts, continuing to try and train additional community health workers, maybe expanding into new geographies, as well as maybe you don't have data on seasonality. And then we also know that as become more aware of the fact that community health workers in their community have products, it may actually be a gradual increase in demand for services over time. And a lot of these trends may not be well understood. And so then, as we discussed before, a lot of estimates of your needs are based on good assumptions. And I think that, it's hard to, this is where the art and science comes into, is the good assumptions. We have to rely on those. For example, I've assisted on a quantification in a country that has a large system with no LMIS system for the community health worker level. There was no data coming in. It was a relatively new CCM program, but expanding rapidly. And so there was a lot of uncertainty about how to do quantification. We did have a small survey, a very small scale survey on the services, numbers of services that community health workers were providing in a very small geographic area. During the quantification, that was one of the types of data so that we could look at it. And, we presented it during the quantification workshop and talked to people about what this data meant and was it representative. Sorry, there's a lot of background noise, so if everyone maybe could go on mute if you're not on mute. So in this example, we had to decide whether using this small sample of data, understanding that it was not necessarily representative of the larger, may not be representative, but at least it was better than having no guess. At least grounded our consumption or our forecast in some level of reality, so we could say, yes, we know community health workers are not having children per month as opposed to hundreds per month. Just to give you reality of that. I think I'm on the next slide. It's hard. I think we're a little out of sync. But I think the next one is just thinking about what are some of the additional considerations for quantification for CCM. And I think these are really important and potentially unique to CCM, is that it's not necessarily a program. It's like a program that has dedicated funding. It's really doing a quantification for a level of a system. Often CCM doesn't receive dedicated funding just for their products, and it may, the program may rely on products already being available through the system. And part of the concern with that is that in many settings, already essential medicines are not in full supply. And then the idea, if it's the same medicines being used throughout the system as are used for community health workers, they are at the end of that supply chain. And so if there are already shortages, it's very unlikely that enough products will reach the community health workers. And so the example on the slide of amoxicillin is pretty common, and we've seen a lot, where there are frequently programs that say, well, for our CCM program, we're just going to use, there are already antibiotics in the system, and so we'll just use those for our CCM products, for our program. But if the additional needs required for community health workers are not included in the forecast that's done for the overall product, it's likely to underestimate the need. Additionally, if you're doing a quantification for CCM and you're just looking at the amoxicillin that's needed for community health workers treating pneumonia in children under 5, you're overlooking all of the other reasons that amoxicillin is used for, and therefore will underestimate what's required of this product. And so these are some of these additional considerations that we need to be aware of while doing a quantification for CCM. So we've talked a lot about the challenges of quantification and quantification for CCM. So why, if we have all these problems with data, why would we take the time and money it's required to do a quantification to do it regularly? And, I think the basic answer is that it is a really important part, and even if you're starting with imperfect data and your outcome has a lot of uncertainties built into it, It's an important process to start. There should be a starting point, and doing it regularly will help ensure that you're monitoring things, monitoring consumption and fluctuations in demand, and each time you do it, your quantification will improve. And therefore, and even just having some data as a starting point to get products into your system and try and rationalize that level so you're not over quantifying, and ending up in situations with overstocks, and also making sure that you're doing your best to avoid shortages and stockouts. It's also really an important platform for discussion and coordination around the need, both for products in the system overall, but also for CCM specifically. But as I mentioned, because of some of the issues with using the same products for different presentations or different levels of the system, it does require a slightly different approach than other more vertical programs. So that approach, moving on to the next slide, that we've used in a number of countries, is really understanding how can we use quantification to sort of share what is needed in total. So doing a quantification for CCM as a subset of the total needs that's used all in aggregate at all levels. So forecasting first for all conditions for which the products are used. So this would be ideally at a national level and involving partners, donors, anyone who's involved in procurement of products to ensure that your overall quantification for these products is detailed and robust, and there's a lot of confidence in that. And then understanding of that, what percentage of total needs does the community represent? So if these products are used at various levels and for various conditions, what is that percentage of CCM needs? So then you can understand, based on what you know as the funding that's available, if you know that your community level consumption represents 20% of your total needs, yet your budget of these total needs, the budget you have available, is only 70%. Without some sort of effort, the products are unlikely to reach community health workers. So that sort of gives you a sense and allows a starting point for conversation around understanding what CCM represents as a proportion of your total need. So the next step then is developing a supply plan. So using the information you have, and this is where you can really use the quantification as your coordination tool. So bringing together the appropriate people that have information on funding availability, programs, and using it to determine how funding or procurement should be planned to maximize the resources you have available. Coordinating. Often there are many people that have funding available at different times, and so determining how you can coordinate procurement to using that plan to understand when products are needed in industry. Okay, the ministry is going to buy this much of a product, but their funding is not available until 6 months from now. So who in the meantime may have funding that could do a procurement now so products in 4 or 5 months? And then, as you know when funding becomes available, adjusting the timing of your procurements and delivery schedules accordingly so that you can ideally avoid stockouts, but also avoid overstock. So you don't end up with maybe 3 different sources of funding becoming available and a large shipment arriving all at the same time, especially when you have a forecast that may be built on a number of uncertainties. You want to figure out a way to coordinate shipments, but also stagger them in such a way that you don't end up with potential overstocks. So that said, from experience, it's actually this step that I think is really one of the most challenging from a forecasting and quantification and supply planning perspective. Often when you have this level of coordination that's required is really difficult. There may be either information that's not available that you would like to have, or it's just difficult to to coordinate the level of information that's needed for this. And then you may find out that funding is insufficient, or maybe there's potential funding, but it's not certain. So how, and then the idea that even your forecast using essential medicines data, if you're looking at the total need, sometimes that's based on just historical order data, and in a number of circumstances I've been in, the essential medicines, if it is a program, may use data from just what was procured the previous year. And if there are already shortages in that, let's say funding was not sufficient in previous years, that using that type of forecasting method will just perpetuate shortages. So it's also, that can make this challenging as well. If you're relying on that as your total need, you still may end up in a situation where it's still difficult to arrive at in a situation where there's enough products guaranteed for the community level. So, what can be done? What can we do to try and improve this situation? The first, and I would say most obvious, but also maybe one of the more challenging one, is improving the data quality and visibility. And some of the previous webinars on supply chain management for CCM have touched on this, as far as inventory control procedures and setting up reporting systems for community health workers to promote visibility, including some of the mHealth topics that were covered in the last, and options for capturing community-level data from the last webinar that was done. Also, different ways. There are many paper-based systems for LMIS that can work to make sure that the community level is captured separately from facility, so it's different from health center consumption. So you're able to use that data. Again, as we'll say over and over again, when there are assumptions that are used, making sure that these are revised and reviewed frequently. And so there are a lot of resources available on this topic as far as data systems for community health workers, and trying to set those up so that you at least have access to the data that you would like for this. And then there are additional issues of how then to ensure that the accuracy of the data through supervision and other different types of oversight for community health workers to not only have this data, but ensure you're actually getting the data you need and to use for quantification. Another option is to then use, really using the supply plan and the output, the quantification report, as an advocacy tool, and using it to bring stakeholders together to discuss what is that funding shortfall. And if we know that the funding that's available currently for all of the medicines in the system and CCM is insufficient, and what percentage of that estimated need CCM represents, that is a really powerful tool to say, if we're not funding this fully and don't have the medicines that we need, this is the risk to our program. If we have this many community health workers that are out providing services, but if we know we're already in a situation where they're not going to get the products they need to treat the patients that are coming to them, that represents a significant risk to the program. And so using that as a way to really gain some support and hopefully identify additional sources of funding to make sure that this program is well funded, and that there's consideration about how to get those products to community health workers. Another option to consider is using unique products for the community health worker level. I think in general, using pediatric specific products and presentations, and this too was covered in one of the previous webinars about why certain packaging is more appropriate for community health worker distribution, like having the blister packs of dispersible tablets ensures that when you give a caregiver the product to take home, the product is well protected, and it's easy to, ideally, it's an opportunity for putting instructions on use that would be appropriate for community health worker and that level of the system. So there are some advantages in that way, but there are additional advantages in having product that either unique just to the community health worker level or packaged specifically, whether it's a unique formulation or packaged differently for the community health worker level. It makes it easier to both quantify, because you really are only quantifying for the community health worker level, and it also makes it easier to track what's being dispensed of these products and ensure that they're not used at higher levels of the system. There are some minor drawbacks to that. It does reduce your ability to transfer products between different levels. So you can't say, well, we have a lot at the health center, so we'll give more to the community health workers, or vice versa. So it reduces a little bit of your flexibility, but the products pictured on this slide are from Rwanda, and so the experience, they do use unique products for most of what the community health workers have for CCM, and it does make things a little simpler in that when you do a quantification, it can be done just for the community health worker level, because that's the only level where these products are used. And it also makes there are some advantages for tracking products through this system. And so there may be some higher costs with either doing unique packaging or having different formulations, but it does seem to be an effective solution for ensuring products actually get to the community health workers. And then lastly, I think it's an approach that does require a little more policy level intervention, and really making sure that it's clear throughout the system that getting products to community health workers is a priority, and how to set up a distribution system that promotes that. I think, when setting up a system, often CCM has been sort of an add-on where it's just an extension of whatever is done to get products to the health center. It assumes that will work to also get products to community health workers. And I think, as Jane and I have talked about, there are some limitations in that assumption. And so I think there needs to be a little more careful and deliberate consideration of how products to get to community health workers, and thinking about how to remove barriers for that flow, or anything that might create competition for products at the health center. If there's a cost recovery at the health center system, thinking about how then what the incentives are for products to get to the community level, and that's where unique packaging may make it more feasible to keep products separate if there is a cost recovery system at the health center, but also just aligning the goals and discussing how to sort of see the health center and its attached community health workers with that health center as a unit, and having common objectives for treating that catchment area, rather than anything that would seem to put those different levels into competition. So, just to wrap up on the key messages and what we've learned from what we've done about promoting product availability by using quantification and policy is, first, reiterating that quantification should be routine. It is the first step. It should be done regularly, and it should be reviewed very frequently, because any quantification, any forecast, there's no perfect forecast. And so whether your program is new or old, the same holds true. It should be reviewed regularly, especially with new programs or quantifications that are based heavily on assumptions. It's critical to do this regularly, to track where you are and to make adjustments as needed. Because, especially trying to get to community health workers at the end of the supply chain, they rely on these products getting to them, and it's important to make sure that this is monitored regularly, and if products are not getting there, making adjustments as quickly as possible. And lastly, just this idea of coordination and using the information you have from a quantification to improve coordination, and also policies to promote distribution of products to community health workers so that they can have what they need to have the intended impact on child health. So it's, quantification, I think a lot of times people talk about quantification not necessarily being done right or people don't have skills or input to do, but it's also linking quantification to, it's very importantly, to the funding that's available and using it to advocate for the right level of funding for these programs, and also coordination. I think probably anyone who's listening to this is aware of the potential impact of community case management and all that's been invested in training them, and so therefore now we can be using quantification and a supportive policy environment to ensure that community health workers have what they need to have the desired impact on child health. So the last slide is it's a partial list of resources. There are many resources that are available on quantification. This, as Jane had said at the beginning, this is meant really just to be an overview and talk about some of the issues that are specific to doing quantification for CCM. But there are a lot of more technical resources that are available on how to actually conduct a quantification, ideas for putting together a quantification workshop, software that's available to assist with both the forecasting piece as well as the supply planning piece. And then there are other online resources available. And then both my contact information and Jane's contact information is there on the last slide, and we'd be happy to be available as resources for questions both now and then later if you'd like to, if something comes up, please feel free to contact us. So thank you.